Intramural hematoma is characterized by the presence of blood, by the presence of hemorrhages within the media. That can happen because of bleeding of the vasa vasorum or involvement of intimal or not. So we can have small bleedings of the intimal layer, but it cannot be seen through radiographic means. There is a 60% of intramural hematomas to be localized in the descending aorta. There is 30% of chance of intramural hematoma to be in the ascending aorta, and 10% of chance of being in aortic arch. Intramural hematomas, the 10% of them can resolve spontaneously, although between 16 and 47% they can progress to aortic dissection. There are complicated features of intramural hematoma, such as periaortic hematoma, malperfusion, cardiac tamponade, pericardial effusion with cardiac tamponade, and recurrent recurrent refractory and persistent pain. The high risk features on imaging of intramural hematoma in type A and type B are progressing of aortic dissection, increasing of hematoma thickness, and hematoma thickness is getting more and more increasing. For high risk imaging features of type A intramural hematomas can be increasing aortic diameter higher than 50 to 50 millimeters, hematoma thickness of higher or equal than 10 millimeters, focal intimal disruption with ulcer-like projection in the ascending or aortic arch, and cardiac tamponade on admission. The high risk imaging for type B intramural hematomas are aortic diameter higher than 47 to 50 millimeters, hematoma thickness higher or equal than 13 millimeters, focal intimal disruption with ulcer-like projection in the descending aorta, and pleural effusion, progressive pleural effusion or recurrent pleural effusion. There is a variety of intramural hematomas regarding the management. It is recommended, and there is a strong evidence, strong recommendation that type A and type B complicated intramural hematomas require repair. There is a strong recommendation for uncomplicated intramural hematomas that they have to be repaired promptly. There is a strong recommendation of uncomplicated intramural hematomas type B to be managed by pharmacological therapy initially. There is a weak recommendation of uncomplicated type A intramural hematomas for high operative risk patients with no high risk imaging features to be managed either solely or initially with pharmacologic therapy. There is a moderate recommendation for type B type B intramural hematomas that require repair and occurs to the distal arch or descending aorta, zone from 2 to 5. Endovascular repair should be recommended by surgeons with endovascular expertise. There is a moderate recommendation regarding patients who have intramural hematoma type B and they have unfavorable anatomy, and the intramural hematoma is in the distal arch or descending aorta from zone 2 to 5, to be operated through open repair approach. And there is a weak recommendation about intramural hematomas type B with high risk imaging features, but they are uncomplicated features with uncomplicated features to be intervention is reasonable for those patients.